My mentor and dear colleague Matej should originally give this lecture. It is his study, is his brainchild, so please manage your disappointment, but I'm here. The thing is that muscle wasting is not a new concept. More than 30, 20 years we're talking about it. This is one of the study on healthy patients. They paid 10 grown-up males to rest for a few weeks, and they found that the muscle loss of the muscles of lower extremities were significant. Then critical illness, a couple of years later, the first study was 2006, and this is 2013. This one is comparing and analyzing critical ill patients at the same levels of the muscle wasting in the lower extremities that were during the days more pronounced than their counterparts. And here even the protein synthesis was significantly lower in the critically ill patients. More organ failure meant more muscle wasting. In the 2002, the ICU acquired weakness was not yet coined, the term. It was coined paresis, acquired paresis, and it was even then that the data was shown that paresis is very much associated with female sex, number of days in the ICU, number of ventilated days, and with corticosteroid admissions. So a lot of data spanning many, many years. Then we go to the interventions. Two very important ones are early mobilization, but active early mobilization, passive early mobilization didn't show any effect, and better glycemic control. So this glycemic control has had double effect. So early mobilization, lower need for insulin, and better glycemic control, lower incidence of muscle wasting in the ICU. This is one of the meta-analyses done on the many different modes of studies. So they were not only comparing, let's say, survival or the muscle wasting, how would you say it, muscle wasting level, but they were also analyzing pre-clinical effect, sensation effect, and other things with the relevance of neuromuscular stimulation. We are here on electrical activity, electrical stimulation, and later we will talk about magnetic stimulation. Here, this meta-analysis found that a lot of the studies were favored with the neuromuscular stimulation for the patients. But unfortunately, nothing really made any difference on the long-term mortality. Long-term mortality was the same in the control groups and in the interventional groups, but the days without ventilation were, let's say, lower in the interventional groups. This is one of the young patients in Matej's former department, and they're working on a bed bicycle with her during her critical illness during the treatment of some hematological disease. So what should we do about it? We have cycling, protocolized physical rehabilitation, and then functional electrical stimulation were used. Unfortunately, again, during this updated meta-analysis, only protocolized physical rehabilitation was shown to be statistically significantly statistically significant difference between the groups, but again, nothing about mortality was different about those groups, only so the days without ventilation. And then we come to the new era, let's say. We have neuromuscular magnetic stimulation. What is the difference? Electrical stimulation needs direct contact with the skin and electrical impulses. The magnetic field doesn't need direct contact and induces the electrical current in the tissue from a distance, and it goes deeper. The first studies were on the mice. They were comparing crush injuries, then how much the scars, so the volume of the scar, and everything was significantly better in the magnetic stimulation group of the mice. This is the idea for this study performed in our department. But before that, another very critical thing is, why should we even compare something that we already have, so electrical stimulation, with this new method? One of the very, very important things is not only the data we get, but the patient's feelings and the patient's acceptance of the treatment. Very important, pain. Comparison of pain in the electrical stimulation and magnetic stimulation is one of the most significant things that is different. So median scores were very different and lower for magnetic stimulation than for the electrical stimulation. My colleagues Anais Kochir and Matej Podbregar, with the help of our physical therapy ladies, conducted this randomized control study. This was not double-blinded, this is open label. They were registering the patients with sepsis and septic shock, and in the final analysis was 16 patients. One of the lower extremities was randomized to the control group, and the other one was the effect group, or the muscle stimulation, magnetic stimulation group. The point of measuring the thickness was marked, and one of the, let's say, downsides was that they were taking the measurements. So there was no separate team. They were conducting the study and they were taking the measurements. The magnetic stimulator was used by the local provider, and all the patients had 55 minutes per day of the treatment 5 days a week, so 5 days per week, so weekends were excluded. 10 of the patients septic shock, 6 sepsis, and the median all were mechanically ventilated 8 days, and the ICU stay was 12.7 days. Some of them were excluded also because of the days in the ICU were too short. Findings: significantly different muscle wasting. So on day 1 or on day 0, compared to the 9 to 12 days, significantly more muscle wasting in control group than in magnetic stimulation group in both longitudinal plane and transversal plane. This is for quadriceps muscle. Everything was measured always on the same spot, and they were both analyzing the results. 31% muscle wasting and versus 8% in the magnetic stimulation group. This was an additional assessment, was of the muscle power. For the 8 of the patients that woke up, they tested with the medical research scale, and also the power was stronger in the legs that were randomized to this magnetic stimulation group than to the control group. There were problems, very important. The same as electrical stimulation, also this magnetic stimulation can cause injury. In the first 5 patients, we have 3 important thermal injuries before the protocol was standardized with that in mind. So the protocol, how long, which leg, where, was standardized from the beginning. But as we talked before, not all the caregiver team was properly notified about it, and we had 4 or 3 burns before standardizing the technical procedure. So what is important is that this head of the magnetic stimulator must not be in the contact with the skin, but over some wet towel and something about a centimeter away. And also the cords, electrical cords, can get to 40 or more degrees Celsius hot, and they must not be in the contact with the patient. These are very important stuff, and the holder you see on the picture on the right was introduced after those first 3 complications, and then again nothing else happened to the patients. Why is this important? This study was actually terminated prematurely after the 16 patients. Why? Because of these injuries, they decided to do an interim analysis, and was statistically significant. So the study was terminated and published. But the termination was not because of the injuries. Termination was because of the statistical significance, but interim analysis was planned because of the injuries. So only a conclusion. Prevalence of ICU-acquired weakness is still very high. We have not many tools to combat it. It does affect long-term patients' outcome and is very important for prognosis. But functional magnetic stimulation could be another field of research, because it's deeper penetration in the muscles and possible better effects for the patients. Thank you very much.